We have also, I have also a very important comment here that iron deficiency can reduce hemoglobin A2. So that's why we said that it's very important to do screening of the patient with to detect the iron stores, serum ferritin, and as it is an acute phase reactant protein which increases during inflammatory conditions. So it's also recommended to do serum transferrin saturation. Okay. So if we have any cases with iron deficiency, it has to be treated first, and then we do the electrophoresis. Right, and there is also a hint here. As I said, if we have abnormality in one of the beta genes, like single point mutation, and produces one beta S chain rather than beta, so we have one healthy beta and one abnormal S. In that case, we would expect if you do the electrophoresis, that 50% of the hemoglobin pattern, you will get 50% A and 50% S, and this is not true. Never happens like that. It's always we have 50 to 65% hemoglobin A and from 30 to 45% of hemoglobin S, and this is very important in the interpretation. Why is that? Because simply the alpha chain has a higher affinity to the beta chain rather than the S chain. So always keep in mind that if you find discrepancy, it has to be interpreted with caution. We have also, if the patient has a coexistent inheritance of alpha thalassemia trait, it even lowers the hemoglobin S than 30%. And I will show you cases, real cases about that as well. Right. This is like the typical pattern you get when you do hemoglobin electrophoresis for adult case. Here is the hemoglobin A. It represents about 80%, and the hemoglobin A2, and sometimes there is no hemoglobin F. I will just skip all of this and go directly because of the time. Okay, and this is again just a table showing roughly what you would expect from each case. This is the normal, this is the typical pattern, and beta you'll have to have the 3.5% of A2 increase. Alpha thalassemia trait, it might be normal pattern, and I will explain this later. S, you have to have at least 30 to 5 S trait, 30 to 45 hemoglobin. Then hemoglobin S disease, which you have two abnormal beta chains, you get no hemoglobin A, and this is very important. No hemoglobin A, right? And S beta FAL, you might have one gene, abnormal gene with S, and the other one with beta FAL. Beta FAL in general, we have two types, either beta naught or beta zero, which is, in this case, there is no beta chain production, and in this case, you have no hemoglobin A. Sometimes it's beta plus. In that case, you will have a remnant of hemoglobin A, but never exceeds 25%. This one. Okay, yeah, and this is just the paper which we published with Professor Ahmed Allam and Professor Dua. And I remember on these days, he worked hard. He did a lot of work, and maybe that was the first ever paper done using flow cytometry, maybe in the Upper Egypt by that time. and Dr. Dua, and she was kindly to allow us to use the flow cytometry in the في معهد أورام جنوب الوادي. There is a hint here, the paper published in 2006, and even we did the work. I remember when I just arrived after studying in the UK, just arrived, and Dr. Zainab Diab, rahimahullah, asked me to if I have any idea for an MD thesis to perform for Dr. Ahmed Allam, and actually he did a tremendous amount of work. And Dr. Ahmed Allam has his way. I don't know how he persuaded the people, normal donors, to give bone marrow samples as a control. That was very clever from him. And I remember we had to go and forth and back from Asyut to perform the test. Thank you, Professor Allah. And again, these are the papers. Just to show you the amount of the work, he did flow cytometry using anti-CD34 as a marker for the stem cells, anti-glycophorin A as a marker of erythroid precursors, anti-CD95, which is the apoptotic marker, and also he did intracellular BCL2 and BCLX staining, which are anti-apoptotic cells. He used also a 780 marker to study apoptosis in different cell types, and he also performed assay for TNF alpha and TNF in the serum and bone marrow plasma. It's just some morphological things. Okay, let's go to the fun part. Okay, here is the normal adult pattern, as I showed you before. Key data here is the 97% A and A2, and CPC parameters are within reference limit for the age and gender, and the interpretation here is normal adult hemoglobin electrophoresis pattern. Right, and this is the neonate. I am just giving you a hint here. This is just hemoglobin is 12%, and hemoglobin F, as you might expect, 88%. And sorry, this is a mistake. There is no A2. So this is just a normal hemoglobin electrophoresis pattern for a neonate. In this case, we have in the CBC microcytosis with an elevated hemoglobin A2. Here it's 5.3%, which is consistent with beta thalassemia case. But in every single case, it's better to approve by DNA analysis. Right. Here in another case, but again, the A2 is 3.7%, which is again consistent with the beta thalassemia trait. Right. In this case, it's interesting. The female patient, she has microcytic hypochromic anemia with a normal ferritin level, and hemoglobin, the electrophoresis pattern is normal. However, we have to suspect alpha thalassemia trait in this case, as sometimes it's completely normal to have alpha thalassemia hemoglobin. The pattern is normal, but the patient still have alpha thalassemia, and in that case, it has to be confirmed by DNA analysis. Here, what do you expect typically of straightforward of a case of hemoglobin A alpha thalassemia when you have A2 less than 2%, as this case, and also you have to have the erythrocytosis, and you have to also to have normal serum ferritin to exclude, because as we said earlier, that iron deficiency may also produce reduced hemoglobin A2. Okay, here a case of hemoglobin H disease. Hemoglobin H disease, we have 4 alpha genes. When you have mutations or deletions of 3, in that 3 alpha genes, in that case you have excess beta and excess gamma. So in that case you will have hemoglobin H here band, which we call it fast moving band, because this is the direction of electrophoresis, fast moving band. So it's 21% hemoglobin H, and the remnant hemoglobin part, which is 4 gamma, and it's if in that case the patient might have remnant of hemoglobin F, and it gave the part hemoglobin. You have also reduced hemoglobin A and reduced hemoglobin A2. Although it's straightforward, but it's better to do DNA analysis in every single case if you can. Right, in this case, we have reduced hemoglobin A2 and normal MCV. In this, the interpretation we call it silent carrier. But I would like to emphasize silent carrier of alpha thalassemia, but I would like to emphasize now again that it has to be confirmed by DNA analysis. Right, hemoglobin S trait. In this case, you will have reduced hemoglobin A and abnormal hemoglobin S band, and normal A2, which is again is from 2 to 3.5%. As you can see, as we said earlier, it shouldn't, the hemoglobin S band should not be